was dispatched to the patient's residence. 13:56, they arrived to find a 79-year-old female, pale, diaphoretic, and clammy, seated in a chair. Patient states the pain started approximately 25 minutes prior to calling EMS while talking on the phone. 13:58, a 12 lead was obtained, an inferior STEMI with elevation in B4. 13:59, vital signs obtained, 137/71, heart rate 62, 95% on room air, respirations 23, pain 4 out of 10. Between 1403 and 1405, aspirin was administered and 18 gauge inserted into the left AC. Normal saline wide open, 8 milligrams of Zofran administered. At 1409, repeat vitals revealed 50/39, heart rate 51, 90% on room air, respiration 17, pain 4 out of 10. Patient now complaining of blurry vision to vision loss. At 1411, a 16 gauge was inserted, normal saline wide open. 1418, 2 microgram push dose epi administered, and at 1422, another 2 micrograms of push epi administered with improvement in vitals and vision loss. Okay. I'm not moving. Okay. 1425, patient arrived in the ED. A STEMI was confirmed. Patient with STEMI presents in cardiogenic shock. EKG presenting inferior STEMI with elevation in V4. Hypotensive and bradycardic. Initial push dose epi after fluids failed to produce meaningful response. An epi drip initiated. Pressures 64/45. Heart rate 48. Respirations 18. 94% on 3 liters. Pain 10 out of 10 with radiation to neck with nausea and short of breath. Pain described as constant and substernal pressure. 1427, ED physician spoke with cardiology. Cath lab paged for STEMI management. At 15:15, the patient arrived at cath lab, and at 15:22, the procedure began. The balloon catheter across target lesion with difficulty at 15:30. Drug-eluting stent successfully deployed to mid-RCA, reducing the blockage from 100% to 0. Patient transferred to ICU and discharged 3 days later. Door to balloon time was 55 minutes, with great difficulty crossing the lesion. The patient had to be taken back to cath lab the following day. He was initially taken on 6/19 from the ED, and due to heavy calcification, required cutting balloon angioplasty, as well as laser atherectomy. Team was unable to fully expand balloon or deliver the stent. The blockage was reduced at that time from 100% to between 40 and 50%. The patient admitted to ICU, and echo was completed the following day, and patient returned to cath lab for planned rotational atherectomy and PCI of heavily calcified mid-RCA, at which time the blockage was reduced to 0. Something to think about. Union was only notified of the incoming STEMI during the IHERN report when the patient was 5 minutes out. Perhaps if the report had come in sooner, the team could have been ready and cath lab could have been in place. EKG transmission, I don't know at the time of this if they had that capability or not to transmit that. Nitro was not given, and pain was 4 of 10. Vitals initially were 135 over something, I believe. I know the pressure dropped significantly, but nitro was never administered and nothing was given for pain. So just something to think about. Door to balloon time, we're at 100% so far for the year. Thank you. Does anyone have any questions?
We're contraindicated in giving nitro with pressures of that low, which is probably why we did not give nitro.
Right, and I understand that. Initially, the pressure, even at 135, is a contraindication?
No, I'm sorry, I apologize. I saw it when it was super low.
Okay, all right, thank you. Yes. Hold back on the nitro. Okay, just an observation.
Absolutely.
So,
Thank you very much.
Thank you.
All right, next up is going to be Beth. She's going to do our stroke report. This is Beth Harrison, our know-all, do-all stroke lady.
Okay. Good morning, everybody. I just want to start out my presentation with a big thank you. Here at Union Hospital, we've been doing our mid-year service line reviews, and I was responsible for doing the one on our stroke program. And it really gave me a chance to dig down into our data. And there's two big measures that EMS has a huge input on, and that is our door to needle time and our door in, door out times. And our door to needle time this year through HFAP and American Heart Target 3 stroke guidelines, the benchmark, I should say the target for door to needle is 30 minutes. And that is an incredible amount of work to get done, get that TPA given within that 30 minutes. But that all starts out in the field with you guys. When you guys call these stroke alerts in, you guys identify those large vessel occlusions. It helps so much. And also our door to needle time has been really, I'm really proud of that, has been reduced. And also our door in, door out times. That means from the time they hit our door, and we treat them for stroke, work them up, see if they need a thrombectomy, and we get them out the door in 2 hours, which that's an incredible amount of work. And we're really seeing a big decrease in that. And you guys do have a big part in that, so thank you. This report was kind of an interesting one. This was a 69-year-old female. Her last known low was approximately at 1400. They called the ambulance, and you guys were on scene at 1414. The patient was not cooperative at all. She was actually a homeless person in a homeless shelter. She was very confused, had right facial droop and slurred speech, and her initial blood pressure was 268 over 142. At 1421, 10 milligrams of labetalol was given IV, and a stroke alert was called to Union ER. At 1436, she was in CT. She went directly from door to CT. And when that CT was completed, all of her stroke symptoms had resolved except for her hypertension. The patient actually got off the CT scanner bed and walked back to ER and refused further treatments. And at 1456, she signed herself out AMA. Well, at 1736, EMS was called back. She had fallen in the kitchen. Her right side was now totally flaccid. She had severe facial droop and slurred speech. At 1751, she arrived at Union ER with a stroke scale of 14 and a blood pressure at 249 over 142. The CT scan was repeated, and it showed no bleed at that time. So aggressive blood pressure control, we gave labetalol at 1806 and 1818, and nitro drip was started, and we did get her blood pressure under control. And at 1831, alteplase or TPA was administered. She had a 40-minute door to needle time, which was really due to that aggressive hypertension control. It took a while to get her pressures down. At 1900, the patient continues to be very hypertensive, and nicardipine drip was started. In 1945, we took her back and did a CTA and a CTP. And during that scan, she deteriorated rapidly and required intubation. She was taken up to the ICU, and then she was taken back down to CT at 2127. And that CT showed a hemorrhagic conversion of her infarct. She ended up having a massive thalamic and cerebellar bleed. And unfortunately, 5 days later, this patient was terminally weaned from the ventilator. We did everything that we needed to do. We got her here. It was identified in the field. We got that blood pressure under control. We treated her, but maybe if she hadn't left AMA, she would have had a better outcome. But this is just one of those cases where we did everything right, but we just couldn't save her with the stroke. It was a massive stroke with that blood pressure. She bled. Anytime you get that hemorrhagic conversion of a stroke, they have very poor outcomes. Do you guys have any questions for me?
Thanks very much. Next up is Jackie Martin, who's going to do a couple cases for trauma.
Thanks, sir. Okay, so you guys always ask, what can we do better? Where are we messing up? And honestly, you do a really, really, really good job with trauma. I will tell you, Dr. Mark and I see every case. We literally review 100% of the trauma cases that come through here. And there are little things here and there, but for the most part, you guys really do a phenomenal job. And so when I pick cases, I want stuff that we can all learn from, both sides, in the hospital and outside the hospital. So the cases I picked today are, one of them is so the one thing I think that we all do, myself included, is we tend to blow things off because especially if we've done this for very long, I used to make fun of my husband for saying things like, I'm not giving them pain meds, or they can walk, right? And so now I find myself doing things like that. So it's really easy to go, I've seen this person 6 times in the past month, or, you know, it doesn't look that bad. And it's easy to get to assume things when you shouldn't. So I picked 2 cases. One is things that we don't know, and one is things that we don't see. So the first case was a car crash. It happened about 8 o'clock in the morning. At 8:09, the 911 call came in. Dispatched at 8:11, en route at 8:13, on scene at 8:16, left scene at 8:23, and here at Union at 8:30. So the times are really good. So 911 to arrival on scene was 7 minutes. They were only on scene for 7 minutes, and 911 call to getting here to us in ED was 21 minutes. So remember, sometimes it's about what you don't see, right? Because with trauma, there is a lot of things going on that we're not thinking about. So they were dispatched to an MVC with unknown injuries. Patient is still in the driver's seat, conscious and alert, but confused. The vehicle sustained in the EMS report quoted heavy front end damage, okay? But no intrusion, had an airbag deployment, which we know doesn't take very much to do that. They were struck by another car, broadsided, then hit a tree, then stopped up against a brick house. So you have 3 impacts, okay? Patient complained of head pain, neck pain, and ankle pain. She had a positive loss of consciousness. She was unable to recall the events. The run sheet states alert and oriented, so probably not completely alert and oriented if she can't recall the events. C-collar was placed on the patient, and the patient was assisted out of the vehicle and onto the stretcher, okay? Let me back up 1 slide. Struck another car broadside, then a tree, then stopped into the house. But we let her get up and walk out of the car. Vital signs and history obtained. Uh-oh, I'm not going, there we go. So pressures and everything was pretty stable. She was 159/83, 102, 95%. Pain was 4, Glasgow was 15. 5 minutes later, relatively the same. Came to ER, no lights and sirens, okay? So ER and EMS both failed to activate trauma. This is a pretty clear-cut trauma activation because she struck a fixed object. Not once, but twice, okay? So that is at a minimum a level 2 trauma activation due to the mechanism of injury. Struck a fixed object, not once, but twice. So they had a non-displaced longitudinal oblique fracture that involved the odontoid, okay, and an acute T5 compression deformity. She was ground ALS to IU Methodist. So the odontoid, little refresher in anatomy, is the bony projection from the second cervical vertebrae. So if I tell you somebody had a C2 fracture, your red flag goes up, doesn't it? And so it's the first vertebrae that rotates around the odontoid and allows you to laterally turn your head side to side. An oblique means it's not parallel or a right angle, it's literally just a slant, okay? So she had a C2 fracture, and we grounded her to IU. So we let her walk out of the car. Neither you nor us activated trauma. We did put a C-collar on, okay? So sometimes it's about what you don't see. So there it is. Can you see that little protrusion up there? Different angles. My friend Megan put those in for us. This is from the top looking down. So see where it's supposed to be in the middle and it's not, it's off to the side, okay? Hopefully you guys see that. So overall, the care was really good. I mean, she didn't receive subpar care, but there were definitely things that we could have done better, right? Because that's what we want to do. We want to get better at what we do. So there was no activation of trauma, not by you guys, not by us. We both dropped the ball there. The run report had some variances between the check boxes and the narrative, and I will tell you, I kind of suck at those boxes. They confuse me because the way they're worded, I think they say one thing, and then I usually have to go to Barry or one of you guys and say, what does this really say to me? So the ongoing assessment states the mental status was alert and oriented, but she couldn't recall the events. She got a little confused during there. The narrative was a little confusing on arrival. She couldn't recall the events. This causes confusion with medical control. So we're trying to figure out, is she confused? Is she not confused? You know, what's going on here? And if this were a legal case, and it's a car crash, so it could easily be one, The attorneys would probably have a field day with this because the medic contradicts themselves back and forth with that. So be careful with your documentation. But sometimes it's about what you don't see. The mechanism of injury was there. One, it should have been a trauma alert, and two, probably one of the times when we shouldn't have let them stand up and walk because we know C2s can cause some pretty catastrophic damage. So, but the care was good. I have no problems with the way this patient was cared for. It's just trying to get you to think that sometimes it's there even when you don't see it. So this case, and I'm going to preface this by saying I would have done the exact same thing, okay? So you're called for a drowning, 911 call at 12:22, dispatched at 12:23, en route at 12:23, on scene at 12:30, left scene at 12:56, that'll make sense here in a minute, and here at Union at 13:03. So really good times. This happened in West Terre Haute. 911 call to on scene is 8 minutes. They're on scene 26 minutes. That's actually phenomenal considering what they had to do. And then the call to getting here was 41 minutes. So remember, they're called for a drowning. And sometimes it's about what you just don't know, right? We were surprised with this one too. When we reviewed it, we're like, oh, okay. So they're dispatched to a water rescue, and they're advised that on scene CPR is in progress. Sheriff's deputy meets them and says the patient was on the opposite side of the bank of the lake and only visible via boat, okay? So this is the lake on 150, the Isaac Walton Lake. And there's this big, they call it an island. It's really just a big fat sandbar. But anyway, he's on the other side, okay? So the EMT gets on the boat with the monitor bag, O2, and backboard. So this is a little John boat. And so the medic did a phenomenal job recognizing that that boat was not going to hold him and equipment, okay? So what's the number one rule of EMS? It's your own safety, isn't it? So this medic recognized that by getting in that boat, he was not doing himself or that patient a favor. So he did everything he could to make sure that patient got what they needed. So a fire department arrives and they put their inflatable rescue boat in the water. CPR is continuing across the lake by bystanders. So they get an iGel in, he has good breath sounds. The AED says not shockable rhythm. Witnesses said the patient was racing his boat, red flag. And they heard the engine die, okay? Typically boat engines don't just suddenly die unless there's a reason. And the patient was on the backside of what they're calling the island, which is just the big fat sandbar that they race around. Okay, it's very common for races at this lake. He was found floating on his back and pulseless. When people drown, do they typically float on their back? No, they are face down and they sink because their body is filled with water. He's unresponsive. CPR started by bystanders. He was returned to shore via that inflatable rescue boat. They put him in a Stokes. They get an IV in place and give him some epi. He is still asystole, PEA, all during transport. They continue all the ACLS protocols. They get ROSC after they transferred him to ED, but it does not stay, okay? So we do call this a level 1. We would call a drowning a level 1. He loses his pulses again at 13:23, so literally just a minute or so after he got here, ACLS is continued. Doc does a FAST, it's negative. If you remember, we do FAST, that's the ultrasound at bedside to see if there's any abdominal injury. In this case, I think he was looking at the cardiac activity. They intubate, trauma surgeon puts in bilateral central lines femorally, and they call it time of death at 14:27. So it was futile. He was asystole, he was PEA. We never got anything back we could really truly work with. And honestly, I think the pulse we got was probably the cardiac drugs. So we were as shocked as you guys when we get the autopsy report. This old boy has blunt force trauma. So he did not drown, he crashed his boat. And so he had a fractured sternum. Ribs on the right, 2 through 12 were fractured. Ribs on the left, 1 through 10 were fractured. He fractured his thoracic spine at the T8. He had bilateral hemothorax. He had cerebral edema. There were no drugs in his system, and it is considered an accidental death. The autopsy report actually says no water in the lungs. So he did not drown. He actually had a giant blunt force trauma. So the medic made a very critical decision not to go to the patient due to his own safety. So kudos to that medic for doing that. He sent as many resources as he possibly could with that EMT safely. I'm sure that EMT probably had to change their pants when they got back because he just said, here's the defib, here's the airway, get in that boat and go to that patient. And so he did a fantastic job there. There's no notes regarding the boat. If he crashed this boat, I bet there was some debris in the water, or at least the boat was sitting somewhere it shouldn't have been. There was no description as far as where the patient was in relationship to the boat. You know, if he'd had a heart attack and fell off the boat, he probably would have been pretty close to it. They focused on the drowning and overlooked some of the clues that may have actually clued him in. Would it have changed the care? No. No, no, no. The care was phenomenal. Typically, drowning victims are face down and sink because they fill up with water. The lake was hosting a race, which indicated potential high speeds. Like they knew when they got there that the boats were racing. The bystanders stated that the motors stopped, which was a clue that something was wrong. Stop motors do not typically happen. And if they do, they don't typically throw riders from the boat. They can jar you, but they don't typically throw a rider from the boat unless you've struck something. And the run report noted a helmet was in use, but then there was no discussion about how that helmet got off or any of that stuff. So phenomenal care. All right.
Thanks so much, Jackie. Appreciate it. Next up, Chris Thomas is going to do an EMS case review that I asked him to present on a very good case. So.
Okay, this case is actually from just about a month ago. It'll be a month ago tomorrow. And it started with a 911 call to Central Dispatch that they received at 7:50 in the morning for a 58-year-old male that was not breathing. Specifically what had happened was the male's wife woke up to strange noises and movement in bed next to her and found him actively seizing. He stopped seizing shortly after she woke up, and then she noticed that he was not breathing, was cyanotic in color, and then proceeded to call 911 at that point. There was a little bit of a delay getting the call dispatched because Central could not get the RP's address to populate in the CAD. It was coming up as an invalid address. So there was some back and forth between the caller and dispatch trying to get a accurate address for it to populate. So it was exactly at 3 minutes from the time the 911 call was first opened to when it was dispatched. Responding units included a BLS engine company and command vehicle from the Honey Creek Fire Department. They arrived on scene at 7:57, so just about 4 minutes after the call was dispatched. My unit, Medic 89 from Transcare, was sent. We were on scene just a little under 4 minutes after Honey Creek made scene, and then there were also 2 deputies that arrived on scene. When we got there, there was actually a little bit of delay making it into the house because we weren't sure which house it was because the way these houses were staggered and they weren't numbered. And the way the engine was parked, you couldn't really tell which house they were at, of course. So the deputy was actually getting ready. There was a deputy that arrived with us, and there was already one on scene. So he was getting on his radio to hit up the one that was on scene to figure out which house they were at. And then, of course, it ended up being the one that was at the top of the very steep driveway that we couldn't get the vehicle up. So we had to haul up there, carrying all of our equipment with us. Then we make it to the front door. There's another 6 steep steps into this house, and it's a big, huge house, 2-story house. And we go inside and we holler, you know, because we don't hear anything. We're like, where are you guys? And of course they say upstairs, and it's a spiral staircase. And so we make our way upstairs. When Honey Creek had arrived on scene, they did find the male patient in full arrest. He was still on the bed. Pretty hefty guy, probably 275, 280 pounds. They moved him to the floor. The firefighter that moved him said it was a controlled fall when they moved him to the floor. He was naked, so there wasn't really much to grab onto and really get a hold of when they moved him, but they slid him down to the floor. They started doing CPR. Honey Creek carries the Lucas device, and so they had placed that. It was doing chest compressions when we arrived. They applied their AED at 8:01, so less than 4 minutes after they made scene, the patient received his first defibrillation. And then they did get another shock in prior to us actually making entry into the room. They placed an eye gel. The history of the patient did include some cardiac history. He had a triple bypass a couple years prior. She couldn't exactly remember when, but sometime in the last 2 to 3 years prior to this event. He had been complaint-free the day before, went to bed, no issues. They were planning on getting up and going golfing that morning. And instead, this is how things played out for them. So when we arrived on scene, I was faced with kind of a peculiar sight. We made our way up the spiral staircase and across the landing. And as I walked into the room, he's on the floor, we're doing CPR, and I see a female in a bathrobe kneeling down next to him, and her back is to the door, so I can't see her face. And at first I thought she was just kneeling there, you know, being a supportive family member or whatever. And then I realized that she had her hand on his femoral pulse. And I was like, well, that's kind of weird, you know? So obviously this is someone who's in healthcare or seen too many medical shows. And then she stood up and she turned around, and I kind of had an oh crap moment as soon as I realized who it was. So the patient is the guy on the right, and the female is the lady on the left. And if you don't recognize her, that is Dr. Kirkendall Watson, who used to work here in the county, both at Union and Regional, and served as one of our interim medical directors for a while. And it was her husband who was on the floor in arrest. So she knew me, and she's like, Chris, and I'm like, what's going on? But I'm thinking, oh crap. And so she proceeded to tell me the history of what had happened. And so at that point, we just basically did what anybody would do. We did standard ACLS protocols. He was still in VFib upon our arrival. So he was intubated. We established IO access. He had very poor vasculature. We could not get venous access in the field. The IOs were flowing great. They took med pushes just fine. They were working great. So he got epi, he got amio. He was shocked a total of 9 times. That includes 2 by the fire department and then 7 by us. He had good CO2 readings. He had good pulse ox the entire time we were working on him. Went ahead and checked the blood sugar just to rule that out as any kind of component. It was 90. And when we achieved ROSC at 8:32. So total downtime was roughly 40 minutes, give or take a few minutes. During this entire time, Dr. Watson, I still call her Dr. Kirkendall, but Dr. Watson, she was yelling at him, you're too stubborn to die. Sure enough, 40 minutes into it, we got pulses back. So initially post-ROSC, he remained unconscious, but he had very brisk pupillary response. He had great pupillary response. He was making spontaneous respiratory effort phenomenally. Like he immediately started to have a spontaneous respiratory effort of like 20. As a side note, during the entire arrest event, he had agonal respirations the entire time. He was drawing agonal respirations. He also was eliciting a moaning and groaning noise. He wasn't gagging on the tube. It was actually like a groaning noise, like he was in pain, which when you see the marks that those Lucas devices leave on the chest, I mean, I can imagine being in pain. And then I also noticed when I would push meds through his IO, he would withdraw his leg. So these were obviously all promising signs immediately following ROSC after a 40-minute downtime. His initial vitals were a BP of 97 over 59, heart rate was 69, respirators were 19, sats were 97% on, I think they had the tank all the way up to 25 liters, and then a CO2 of 39. So not too bad, following such a prolonged downtime. This was his EKG. So obviously global signs of ischemia, totally understandable in a situation like that. Some questionable elevation in the inferior leads. Dr. Watson actually took a picture of it, and because she had been on the phone within 5 minutes of us getting there with his cardiologist, saying, he's had a heart attack, they're doing CPR, et cetera, et cetera, et cetera. And after this, she sent a picture of the 12 lead to the cardiologist. So additional treatment, we did end up having to give him 3 rounds of push pressor epi because his pressure kept tanking. At this point, we're still in the bedroom trying to get him to stabilize package for transport, to get him down, figuring out the safest way to get him down from his location, down the spiral staircase and so forth. While he was being moved down the staircase, his ET tube did come dislodged. I had actually run outside back to the truck to get some ketamine to sedate him a little bit because it was going to be the most blood pressure friendly sedative, and he was really bucking on the tube and this kind of thing. And when I came back in, they were bringing him down the stairs, and I immediately noticed the ET tube sitting like this. I'm like, oh, that tube's out, and the cuff was in his mouth. Luckily, by that point, he was breathing spontaneously enough on his own that it wasn't too terrible. So we did support those respirations with the BVM until we could get him out into the truck. And at that point, he was subsequently re-intubated using an RSI at this point, because now he's breathing, he's clenched, and so we now had to do a full RSI procedure. Went ahead, threw in another IO, started an amio drip, put him on the vent, and transported him to regional at that time. So by the time we arrived at regional, his vitals were 112 over 68. He was not requiring continuous pressor support. I just gave him those 3 rounds of push pressure doses upstairs, and after that, he held his own pressure. Heart rate was 85, respiratory rate was 14, sats were 98% on FiO2 of 100 on the vent, CO2 was about 31. I was not able to get the subsequent ECG to put in here, but it actually did show improvement from the first one that we had taken immediately post-ROSC. He was seen briefly in the ER and then taken directly to the cath lab. I mean, they threw in a couple IVs, and that was pretty much it, and he went to the cath lab. We were in the ER a very short period of time. Cath lab results did show 100% blockage of his RCA and 70 to 80% blockage of his other arteries. but a good point that was made was that was probably his native arteries and not the bypass placements. Anyway, no interventions were done in the cath lab because he was essentially too unstable. He did actually end up rearresting. It was a VTAC arrest the second time, and he was moved to the ICU at that point. So that evening, he actually self-extubated. And I guess he came out talking. He literally was yelling. I actually just spoke to her last night, and she said he pulled the tube out and screamed, "You're trying to kill me." Was very agitated. They ended up resedating him. They spent a couple days doing a lot of tests. You know, they did an EEG, which showed diffuse myelencephalopathy. He had to be on continuous sedation. They did an echo. Ejection fraction only showed about 10%. Over the next, he was there for 4 days. They had to keep him sedated. They did have him on pressors for the first couple of days, but they were able to titrate him off the pressors. He was holding his blood pressure. He was satting okay. So this all started on a Sunday. On Thursday night, he self-extubated again. And she made a point to tell me he was actually in restraints at the time he did this. So there obviously was a lot of slack on those restraints that he was able to self-extubate. But at that point, they went ahead and left him off the vent. His agitation continued, so they just kept sedating him, kept sedating him. She went on to tell me that one of his brothers ended up chiming in and telling her that the family, the males in the family, have a history of coming out of sedation very combative and agitated. And so I guess with that information, they kind of took their approach to sedation a little differently and really kind of like weaned him off nice and slow and let him just wake up. And that worked. He subsequently was able to wake up without these periods of combativeness rather. They did end up transferring him up to St. Vincent Hospital. He had an AICD placed. Ejection fraction improved to 51%. St. V docs basically said no STEMI. That is just VFib in origin that led to the arrest. The EKG changes were due to hyperkalemia and the acidosis that had set in throughout the arrest period. He was discharged from St. Vincent exactly 2 weeks after the date of the arrest. We actually were able to see him last night. Dr. Watson and Max treated us and the crews from Honey Creek to dinner, a thank you dinner last night. So we were able to actually see him in person last night. He's actually doing phenomenally well. He had no slurring of the speech. He has a little bit of short-term memory loss, but he's able to carry conversation. He has no motor function deficits or anything like that. His sense of humor is intact, which he wasn't necessarily amused by in some cases last night. But you know, he just continues to improve one day at a time. So just some key takeaways from this, you know, this literally showed all the steps of the AHA chain of survival in place: early recognition, early CPR, early access, early ALS care, continued care in the hospital to discharge and rehab. It also showed some benefits of mechanical CPR. This is a big guy. We did CPR, you know, for 30 minutes once we were all on scene. And, you know, I mean, we had a decent amount of people there. We had a total of 8 people between EMS, fire, and law enforcement there. So a lot of people to rotate through, but obviously the Lucas delivers consistent, uninterrupted chest compressions, which I'm sure made a difference in this particular patient's outcome. So he lives to tell the tale, and we actually got to see, you know, good outcomes from putting our things in place. So that's that. Thank you.
Information regarding the family history would have been useful 2 days before that, but anyway. All right. So our final presentation today is from Leslie Probst. She is going to be talking about toxic syndromes. We had a couple situations happen, so I asked her if she would present on this, and she said she would love to present on this. So Leslie.
Yes, thank you, Barry. I do love early morning presentations when I work evenings. It's great. No, I am happy to be here. I always enjoy coming and spending some time with EMS folks. I have to say that's one of my favorite things since moving to the ER from our adult ICU is getting to be familiar with what happens in the pre-hospital setting. So it's always a good time to come. So as Barry said, we're going to talk about toxic syndromes today. And this is something that I find really interesting. I feel like toxicology is one of those really cool areas in emergency medicine, pre-hospital medicine. And it makes a really big difference on how we treat these patients initially. And sometimes we've really got to use these toxic syndromes to identify what these patients have maybe been exposed to. So today we're going to just talk about toxic syndromes or toxidromes, define that, talk about what it is. We'll describe the autonomic nervous system as well, because most of our presentation of these patients is a response of the ANS. And we'll talk real quickly about common receptors that are responsible for these classic toxidrome presentations. We'll talk about the vital signs and in-organ manifestations for these common toxic syndromes and describe the initial treatments for these patients. So toxidrome is a term that was coined back in the 70s, and it's just a combination of the words toxic and syndrome. So it just makes it a little bit easier to say toxic syndrome instead of, or toxidrome instead of toxic syndrome. But these are a group of signs and symptoms that consistently result from particular toxins. It's a combination of our vital signs and those changes that we see and clinically apparent in organ manifestations that are pretty routinely seen with certain types of toxins. So I will mention that some patients will have that classic toxidrome presentation, while others will not. So sometimes they may have components of those toxic or toxidromes. However, a lot of our patients will present with kind of a mixture because they have multiple substances that they've been exposed to. So sometimes you have to take bits and pieces of what they present with, but we're going to talk about our classic presentations of these different toxidromes. So these are our common toxidromes that you'll see: anticholinergic, cholinergic, ethanol or sedative hypnotic, opioid, serotonin, sympathomimetic, and then our 2 withdrawal syndromes. So when evaluating these classic presentations, we first need to take a little bit of a review of the nervous system. So we're just going to go real fast over some of this information. So as we know, the nervous system is broken down into central nervous system, brain and spinal cord, and then your peripheral nervous system. Your peripheral nervous system is further broken down into your somatic system, which controls your skeletal muscles, so motor output, as well as your sensory input. So that's on that somatic side. And we'll mention why that's important here in one of our toxidromes. And then our autonomic nervous system is our other section of our peripheral nervous system. So the autonomic is then further broken down into our sympathetic and parasympathetic systems. We're going to focus for just a second on that autonomic side. And our autonomic nervous system functions below the level of consciousness to rapidly control visceral functions. This is why we can use this to identify certain toxins because patients can't control it. So whether they want to dilate their pupils or not, it does. It happens or it doesn't. So this is why we can use these symptoms for identifying certain toxins. There are 2 main branches, as I mentioned, of the parasympathetic, which is often referred to as your rest and digest, and then our sympathetic nervous system, which is often called our fight or flight arm. You can see the activation of our parasympathetic nervous system results in increased salivation, also stimulates the gallbladder, slows the heart rate, contracts the bladder, all those things that are needed for rest and digest. Our sympathetic nervous system, you can see, activates things like dilates the pupils, accelerates the heart, inhibits digestive activity, all things that are important in a fight or flight situation. I want to take just one more step a little bit deeper and look at our neurotransmitters and receptors that play a role in our autonomic nervous system. So we're just going to take a bird's eye view of this, but you can see that in our sympathetic nervous system depends on the release of norepinephrine, also dopamine and serotonin to a certain extent, but norepinephrine and often agonizes our adrenergic receptors, and it also has plays a role in our acetylcholine as well and muscarinic receptors for just a little bit, and that'll make a difference in some of our presentations. And then our parasympathetic nervous system relies on acetylcholine and our muscarinic receptors. So this will play a role when we talk about what these patients present like. I will also mention just real quick that our somatic system does also depend on acetylcholine as a neurotransmitter, but it acts at nicotinic receptors. Again, we'll see how that plays a role. So I just want to take a brief section or brief moment on that. So all these receptors, all these autonomic nervous system, what does this mean for our patients? So generally, we're going to see a change in our vital signs: blood pressure, heart rate, respiratory rate, temperature. You might see a change in all of them. You might see a change in none of them. But you're definitely going to need to assess our vital signs. And then I mentioned you'll see your end organ manifestations. So those that are most clinically useful is looking at our CNS with our mental status, pupil size, GI motility, peristalsis, either looking for dry skin or diaphoresis, dry or mucous membranes, moist mucous membranes, and urinary retention. The right combination of these different changes will help us identify the specific toxic syndromes. So this is a table that lists out our common toxic syndromes and what the response and vital signs and mental status and our other end organ manifestations look like. It's a really busy table, but I wanted to include it all here as a complete reference for you. So we're only going to highlight a couple of these toxic syndromes because some of them are really common and you see quite a bit. But we're going to highlight our anticholinergic, our cholinergic, and our sympathomimetic. Opioid, something you see often. Ethanol, something you see often. Serotonin is not necessarily something that you see very often, but it is very similar to sympathomimetic in a lot of ways and treated very similar. So we're going to focus on sympathomimetic because things like methamphetamine exposure is a higher likelihood than serotonin syndrome. And then also your withdrawal, you guys see those quite often, so I'm not going to touch on those as well. So we're going to start with our anticholinergic agents. You can see that there are a ton of different anticholinergic agents. When you look at this list, notice a lot of these say anti. So antihistamines, antidepressants, antipsychotics, antiemetics, antispasmodics, antidysrhythmics. Then there are several naturally occurring anticholinergics as well. So there are hundreds of compounds that have anticholinergic properties. You could have some of these agents that are more purely anticholinergic. For example, atropine is a pure anticholinergic agent. Scopolamine, hyoscyamine, your several plants, a lot of those are purely anticholinergic. Or you could have agents that are kind of a mixed bag. I think of diphenhydramine, TCAs. They all have anticholinergic properties, so you will see an anticholinergic toxidrome, but they don't just have anticholinergic properties. So sometimes those agents can be more toxic because of those other activity that they carry. So these anticholinergic properties, they all start with blockade at the muscarinic receptors. So these muscarinic receptors are found in the CNS, so we'll see some CNS changes: heart, smooth muscle, ciliary body of the eye, and secretory glands. So when we look at the classic presentation of an anticholinergic syndrome, we will often see some changes in your vital signs. Definitely tachycardia is very common in these patients. And elevated temperature can be quite common. Mental status, they'll often present with a delirium. This is a little bit different than some of the other CNS changes where they're not necessarily agitated. This is definitely a delirium. Some will see hallucinations. You might see them picking at things in the air, and that's very common. So they're usually confused, but not necessarily agitated or violent like you might see in a sympathomimetic overdose. Other changes you'll see is dilated pupils, decreased GI motility, so decreased bowel sounds, dry skin. This is a key factor when distinguishing between a couple of other toxidromes. And definitely dry mucous membranes are very common. They might be flushed and have urinary retention as well. So I think in the healthcare, we love our mnemonics and our kind of cute sayings to help remember things because there's so much to remember, and anticholinergic toxidrome is no different. So you may have heard red as a beet, dry as a bone, hot as a hare, blind as a bat, mad as a hatter, and full as a flask. These are all very common presentations of your anticholinergic toxidrome. So these patients will have vasodilation, which is why they are red as a beet or they are flushed. Dry as a bone, dry skin, dry mucous membranes are a classic anticholinergic presentation. Hot as a hare, so they oftentimes present with a hyperthermia. Blind as a bat, they do have pupillary dilation and ineffective accommodation, so they will not be reactive to light. So patients may complain of blurry vision because of that. Mad as a hatter, I mentioned delirium. That's very common. Confusion, disorientation, hallucinations. just bizarre behavior, and seizure can certainly happen with some of the agents that carry anticholinergic properties as well. And full as a flask, urinary retention, definitely a cardinal sign of anticholinergic toxicity. As with anything, our first and foremost, our treatment starts with the ABCs for these patients. Most of the time they're confused, but they maintain respiratory drive and things like that, but always ABCs. As far as looking a little bit at our more specific toxicities, our cardiotoxicity, sinus tach is very common with these patients. So they will oftentimes have tachycardia as an early sign of toxicity for an anticholinergic agent. This in itself is rarely needs treated. So, no need to give diltiazem or a beta blocker or anything like that. It's self-limiting. It'll go away once those agents are metabolized and out of the body. However, there are some agents that have anticholinergic properties that can be toxic and cause a QRS widening. Ones that I think of that are kind of notorious for this are TCAs. It's very common for this, and also diphenhydramine. So these agents also block fast sodium channels in cardiac tissue, which causes that QRS widening, which increases their risk for arrhythmias. So if you see a QRS widening in these patients with an anticholinergic toxidrome, sodium bicarb is a treatment of choice for this, usually 1 to 2 milliequivalents per kilo given IV push. So you're increasing the amount of sodium that's available with these channels to go into the cardiac tissue to help stabilize those membranes. And also, especially TCAs, they kind of prefer a more acidic environment. So as you increase the pH with bicarb, kind of helps pull some of that drug off of those receptors and decrease the amount of widening that you might see. That is part of your protocols for EMS. So in your toxic exposure protocol 3.225, you do have specifically in your protocols for TCA overdose to give bicarb in those situations. And that's totally appropriate, 1 amp or 50 milliequivalents. As I mentioned, this can also occur with diphenhydramine. So definitely Benadryl is one of the most accessible medications because it's over the counter. You can go buy a bottle of 500 at Sam's Club if you want to. And so diphenhydramine, while it seems pretty benign as an over-the-counter medication, it can certainly be toxic. I have seen arrhythmias leading to cardiac arrest due to Benadryl, overdoses, seizures, things like that. So definitely Benadryl can be a very serious exposure in the right amounts. Other things that you might see in an anticholinergic patient is seizures. Again, I mentioned that. I've seen that with a diphenhydramine overdose specifically, as well as their TCAs. So if their patient were to seize, benzodiazepines, drug of choice for that, either IV or IM. Agitation, I mentioned agitation is a little bit different in anticholinergic patients. They're usually just delirious or confused or hallucinating. They're usually not violent or super agitated where you would need to like rapidly tranquilize these patients. So if you can avoid ketamine and antipsychotics in these patients, that would be best because it does have some anticholinergic properties, ketamine does. Should you need that rapid tranquilization, then that's okay. But if you can avoid ketamine, it might be a good idea in these patients because of those anticholinergic properties. Hyperthermia, we always want to try and cool these patients. You can use ice packs or cold saline or LR, either one. And then because there are so many different agents that have anticholinergic properties, the patient history can be really, really helpful because there are just so many options when it comes to anticholinergic agents. So a good history can be a great help whenever they get here as far as definitive treatment for that toxic exposure. So a quick summary for anticholinergic agents, there are hundreds of compounds that are available with anticholinergic properties. Some of them are over the counter, so very readily accessible. So that's where it is important to recognize this toxidrome because it might be a med that you never would have thought had anticholinergic properties. Scopolamine for dizziness or something like that, and the patient overdosed on that. So it could be a lot of different things. So it's important to be able to recognize this toxidrome. It can be confused with the sympathomimetic syndrome because it has a similar presentation, but the dry skin is the key in differentiating the two of those. So these patients will always be dry as a bone. So dry mucous membranes, no sweating on these patients. If you have a patient that presents with an anticholinergic type toxidrome, an ECG is a must in those patients. You need to rule out QRS widening. If that is present, then give your bicarb. And CNS symptoms are an indicator of a more severe exposure. So if you have a patient that is confused and showing those CNS type symptoms, you know that you've got a pretty good exposure there, and just anticipate what might come next as far as seizures or things like that. Okay, the next one we're going to talk about is the complete opposite of anticholinergic, and it is the cholinergic toxicity. So cholinergic toxicity is not something that we see common. I don't know that I've ever seen it in real life, but it is something that can happen, especially after being exposed to organophosphate or carbamate insecticides. So I did want to include it since we do live in an agricultural area, and you might see this in some situations. So toxicity from these agents can develop after a cutaneous exposure, inhalation, or ingestion. So it doesn't really matter how the patient is exposed. They can have toxic signs from it. Often, like I mentioned, it's an accidental exposure from agricultural pesticides. And again, there are many different agents, many different pesticides that are organophosphate or carbamate in structure. They're all a little bit different when as far as onset of toxic symptoms, duration of toxic symptoms, and such. And most of that will change once they get to us, and what we would do for a more definitive treatment. Initial treatment for these patients would stay the same. You might also see organic phosphates in chemical warfare agents. They're often referred to as nerve agents. There was a sarin gas attack in the 90s in Tokyo where patients suffered from this. I also think of the 1996 movie The Rock. I don't know if you've ever seen it, if they're in the 90s folks in here. That's a great show with Sean Connery, Nicolas Cage, and Ed Harris. And Ed Harris's characters threatening the San Francisco Bay Area with VX gas warheads. And VX gas is an organophosphate. So little movie trivia and fun, nerdy stuff whenever you're watching that one. But it's a great 90s movie. You should check it out. So these cholinergic agents inhibit acetylcholinesterase, which is the enzyme that breaks down acetylcholine. So this works a little bit differently than our anticholinergic agents because this just increases the availability of acetylcholine at these neurotransmitters. So you can see the symptoms are more widespread. It's not specific muscarinic receptors, but you'll see it, acetylcholine increase at all of those available receptors. So you just have a kind of a global cholinergic excess. So what does that mean? Because there's a lot of stuff listed here. Very common, you will not see much of a change in your vital signs. I mentioned you have an increase in acetylcholine in all synapses, and they kind of cancel each other out. So you might see an increase in blood pressure, you might see a decrease in blood pressure. You might see a change in your CNS, but not necessarily. The cardinal signs of a cholinergic overdose or toxic exposure are things like salivation, lacrimation, urination, diarrhea, bronchouria, fasciculations, and paralysis. So these are often referred to as sludge. So this is an acronym that you might have heard before. I always remember sludge B, so I can get my bronchouria and bronchospasm bradycardia in there as well. So there's a couple of different mnemonics, but these are very classic cholinergic excess presentations that you will see in these patients. You can notice that this is your muscarinic effects. So I mentioned that this is just at muscarinic receptors, and that these cholinergic toxicities you will see more widespread. So you will see some toxicity at nicotinic receptors, and those are found in our skeletal muscles. So you could see fasciculations, you could see muscle weakness, you could see paralysis eventually in these patients if the exposure is enough. So acetylcholine is the neurotransmitter used for that. That's what succinylcholine is based off of. So if you think succinylcholine, a neuromuscular blocker, it's going to work kind of the same as acetylcholine. So that's why you're seeing that those fasciculations, muscle weakness, paralysis. You'll also see some CNS effects. You could see some CNS effects, including central respiratory depression, lethargy, seizures, coma. Our initial treatment for cholinergic toxicity, of course, is your ABCs. Airway assessment and management, I would say, is the most important here, as most fatalities from organophosphate poisonings generally result from respiratory failure. So it's a kind of a combination of reasons for that. One being central respiratory drive depression. I mentioned the neuromuscular weakness that includes weakness in the diaphragm and ability to breathe. Also excessive respiratory secretions and bronchospasm. So a lot of respiratory activity here. So most patients or most fatalities are due to respiratory failure. In these patients, if you do need to intubate, it would be best to avoid succinylcholine if an organophosphate is suspected. And that's because acetylcholinesterase, which is inhibited by these OPs, also breaks down succinylcholine. So that enzyme also inactivates SUX, and if you use succinylcholine, you could have very prolonged duration because that compound is not being broken down. Could be a very long duration if succinylcholine is used. So that's just something to think about. Our drug of choice in these patients for initial treatment, if you think you have a cholinergic excess, we're going to use something that has anticholinergic properties, and that's atropine. So atropine, initial dose of 2 to 5 milligrams for adults, 0.05 milligrams per kilo for pediatric patients. Generally, you want to double that dose every 3 to 5 minutes as needed, and you're titrating to clearing of respiratory secretions and bronchospasm. So those are the things that you're going to see. If you're still having the copious amounts of secretions, give more atropine. Still having more copious secretions, give more atropine. You really want to give atropine until you see some of those anticholinergic effects, so you know that you have the right amount of blockade there. Atropine is anticholinergic, exerting its action at muscarinic receptors only. That plays a role because our muscle weakness and decreased respiratory ability comes from nicotinic receptors. So these patients may still need their airway secured because they're having muscle weakness or paralysis, but you're still going to secure that airway and still give the atropine to try and decrease your respiratory secretions and bronchospasm. Other things you might see, seizures, obviously benzodiazepines, drug of choice. And I also just wanted to touch on decontamination. So I mentioned that these patients could be exposed topically. So decontamination does become an important thing. You want to remove all contaminated clothing and dispose. So these agents will leach into that clothing, so they cannot be saved. You can't say, you know, save that jacket. It's my favorite one. I'll wash it. Not going to happen. You got to get rid of it. Got to get rid of it. And I would say remove it far from your area if you can, because you certainly do not want to have an accidental exposure for yourself. Copious irrigation of the skin if possible, using water, soap and water, and water. And then I mentioned being cautious to avoid that accidental exposure. It's something that is very definitely a risk when responding to an organophosphate exposure for sure. On your protocols, you'll see at the very top, consider a possible hazmat incident and make sure you have assistance there if you need that, or if you suspect that it might be a more broad exposure. Again, you have your atropine here, 2 milligrams IV push every 3 to 5 minutes. And I would repeat that every 3 minutes as needed until you see the clearing of those secretions and bronchospasm. So the cholinergic toxicity is not common, not something we see often, but it is something I wanted to talk about because it does often occur from accidental exposure to agricultural insecticides, and we certainly have a lot of agricultural areas around here. Symptoms are due to overstimulation of muscarinic and nicotinic receptors, so you have to remember that muscle weakness that can occur, which is a little bit different than some of our other toxidromes. Respiratory failure is the leading cause of death in OP toxicity, so you want to make sure that that airway is well assessed and secured. Atropine is our drug of choice in these patients, and you want to titrate that atropine again to decrease respiratory secretions and decrease bronchospasm. Okay, so the last toxidrome that I'm going to touch on is our sympathomimetic toxidrome. So these agents enhance the release of norepinephrine, dopamine, and serotonin to a varying degree, depending on the agents. So the release of these neurotransmitters results in a hyperadrenergic condition and or hyperserotonergic condition. Common substances that we might see here are amphetamines and methamphetamines, both illicit and prescription. Cathinones would be like bath salts, would be a synthetic cathinone, cocaine, and MDMA. So I mentioned they kind of cause differing levels of release of these neurotransmitters. So for example, MDMA or ecstasy causes a much higher release of serotonin compared to methamphetamine. So methamphetamine, you're going to see a lot more of adrenergic response, where MDMA, you'll see a bigger serotonin response. So in general, the same, but you might see a little nuances in depending on which agent they have been exposed to. So going back to our table, we can see with our sympathomimetic. So again, this is enhancement of our fight or flight, the sympathetic nervous system. So you can see an increase in your blood pressure, heart rate, respiratory rate, temperature, everything gets elevated. These are the patients that can present agitated and very violent. We had one just a couple weeks ago who was crazy. I would say very agitated and violent. You will often see a pupil-sized dilation, no major changes to the gut, and increased diaphoresis. So in these patients, they will be sweaty. This guy was enraged and just drenched in sweat. So it's very typical presentation for a sympathomimetic overdose. Other things you might see, tremors, seizures. Of all the effects that sympathomimetics can cause, one of the most concerning is elevated in temperature. So hyperthermia can be very severe in these patients. So generally, if their temperature is greater than 104 or Fahrenheit greater than 40 Celsius, you want to institute immediate cooling. I think our guy a couple weeks ago was 106 when he first got to us. I may have heard a 108 in there, but it wasn't charted, but definitely 106 for his temperature. So we started him cooling with our body wraps and cold saline. But that's definitely something that you want to assess in these patients when you suspect a sympathomimetic overdose. Definitely check a temperature. Throw some ice packs on, cold saline if you have it, if they are greater than 104. And the other key part of temperature assessment and management is agitation control. So these patients are having a hyperthermia due to excessive thermal generation from muscle activity. So our antipyretics like Tylenol, ibuprofen, those things will not work to control temperature in these patients. You've got to stop the muscle activity. So cooling that patient is great, but you've got to control the agitation in these patients for sure. So we do that with sedation, either benzodiazepines, IV or IM. They're kind of the classic agent that you can use for this. However, there are antipsychotic agents that are great in the setting of sympathomimetic overdose. And ketamine is also an option for extreme agitation or violence in these patients. So if you need to rapidly tranquilize these patients. It theoretically could increase blood pressure. It does have a little bit of catecholamine release. That's one reason why if you think an RSI, it's kind of a nice agent if you have a hypotensive patient. So same thing applies here. It could theoretically increase blood pressure. However, most of the time, once you sedate that patient to an adequate level, that pressure will drop. So really the sedation is most important in this setting, and their blood pressure will generally respond after that. However, if you do use ketamine, you just want to make sure you're watching that blood pressure. Okay, sedation is really important in these patients because we want to try and avoid physical restraints if we can. Obviously, safety for you and the patient comes first. Sometimes you have to physically restrain them in order to get the chemical restraint on board, and that is 100% appropriate. But physical restraints can promote the development of hyperthermia as well as rhabdomyolysis. So as you restrain that patient and they fight against it, you're going to be chasing your tail because that's going to be just generating more heat. And so physical restraints might be a necessity up front, but the goal is to always calm the patient chemically and remove those restraints as soon as possible. If they require intubation, which they might, they say to avoid succinylcholine. I'd say that's a relative contraindication due to rhabdomyolysis. Most of the time, you're not going to see that hyperkalemia in that initial acute setting. You'll see that a few hours later, but just FYI on that. In your protocols, you'll have, notice your cold saline ability to help cool that patient, and then it refers you to your agitation protocol 3.4 as well. So sympathomimetics cause that release of norepinephrine, dopamine, serotonin to varying degrees. So patients present in general the same way with a little nuances maybe here and there. Sedation and management of hyperthermia are the most important initially for these patients presenting with a sympathomimetic toxicity. Benzodiazepines, either IV or IM, are appropriate, or ketamine is an option for your extremely violent patients when you need rapid tranquilization. So quick summary, your toxidromes or toxic syndromes just describe a group of signs and symptoms that consistently result from particular toxins. It's defined by your vital sign abnormalities and end organ manifestations. I will mention you have a reference in your Vigo County EMS protocols, Appendix 6.16, and it just lists out these common toxidromes and signs and symptoms in case you need a reference in the moment. Initial management for these patients always starts with your ABCs, high quality supportive care. However, there could be key findings like QRS widening, hyperthermia, extreme agitation. You've got to treat those promptly and aggressively. And then, as with any patient that's exposed to toxins, a thorough history can really prove to be beneficial, especially when looking at your definitive treatment and when polysubstance toxicity is there, because it might be masking some of those typical toxidrome signs and symptoms. So if you have any questions, feel free to email me and I will try and answer your questions if I can. Thanks so much. Very much needed Diet Coke.
Thank you, Leslie. Thanks to all my presenters today. Much appreciated. Really good. Good audit review. Again, please email me, text me, let me know that you're on watching so I can get you on the attendance list and get you credit. If you have any questions for any of the presenters, be sure and email me and I'll make sure I get the questions to them. Otherwise, a couple things to remind you from our advisory meeting earlier. Paramedics need to do the RSI test outs October 20th, 21st, and 22nd, Wednesday, Thursday, Friday, 9 to noon, Regional Hospital at the Pavilion. If you have not done it yet, those are the only 3 days that you'll have to do it. If they're having vacation, we might be able to get Zach to do an extra day after that, but those are the 3 days that you got to have it. You cannot work in our EMS system unless you pass that and get through it, period. Simple as that. Make sure that all your BLS, ACLS, PALS, either ITLS or PHLS are up to date so that if I request them as a supervising hospital, your service has those available for me at any time I need them, okay? For those of you, I'm not sure if anybody knows, the Indiana Emergency Response Conference is going on next month, September 15th through the 18th. There's going to be some really cool classes, some good classes over there. I have an EMS commission meeting that afternoon on the 15th like I normally do. So if you have a chance to go. If you're a student, they have student discounts. It's really reasonable too. So anybody here have any questions before I end it? All right. Thanks guys, much appreciated, and we'll talk to you guys later.